Morning or good afternoon, everyone. I'm Shelley Hurry, a health and safety consultant with Public Services Health and Safety Association. Thanks, Marina. I'm very excited in presenting this topic today. A little bit about myself. I have a master's in kinesiology, and I am a Canadian certified safety professional and a certified health and safety consultant. I've actually been working with Public Services Health and Safety Association now for over 8 years, and I have about 18 years experience implementing health and safety management systems. My experiences and best practices have been gained through working and consulting primarily in the healthcare sector. I am very passionate about the topic, workplace violence, and addressing responsive behaviors. My former employer was a long-term care facility where I was the lead in the Gentle Persuasive certification training program. I currently am one of the PSHSAs, which is the acronym for Public Services Health and Safety Association, lead consultant for a Ministry of Labor funded workplace violence toolbox project. And of the 5 priority areas that were covered in this toolbox, I led the individual client risk assessment toolkit. So we call the workplace violence toolbox project Barb. I will be talking about that later this through this session, and I will go through in quite a bit of detail actually of the individual client risk assessment toolkit. About Public Services Health and Safety Association, we provide occupational health and safety training and consulting services to various Ontario public sectors. These include healthcare, education, municipalities, public safety, and First Nations communities. As a partially funded partner of the Ministry of Labor, we work to prevent and reduce workplace injuries and occupational diseases by helping organizations adopt best practices. To create safer workplaces, employers and employees must work together to identify potential hazards and eliminate or control risks before injuries occur. For the next 50 minutes, I will provide you with an understanding of the urgency in developing a sustainable responsive behavior prevention program. I'm going to review the prevalence of violence, provide you with an understanding of legislative requirements, provide you with a better understanding of the 5 steps to developing a sustainable responsive behavior prevention program. And then I'm going to introduce to you those VARB tools that I just briefly mentioned. VARB stands for Violence, Aggression, Responsive Behaviors. And I do have a slide that will speak of that in just a moment. So in Canada, there is approximately 350,000 cases of workplace violence each year. Workers remain vulnerable to the effects of workplace violence, with nearly 1 in 5 victimizations of violence occurring at work. Violence does continue to be a growing concern in Canada. The International Labour Organization refers to workplace violence as an action, incident, or behavior that departs from reasonable conduct in which a person is assaulted, threatened, harmed, injured in a course of or as a direct result of his or her work. One jurisdiction defines violence to capture all types of violence. Violence is just not a physical assault. It could be defined as the exercise of physical force against a worker in a workplace that could cause physical injury to the worker. It's also an attempt to exercise physical force against a worker in a workplace that could cause physical injury to a worker. But not just the physical component of it, but there might be a threat to exercise physical force against a worker in a workplace that could cause physical injury to the worker. The research supports 4 types of violence to remind employers and workplace parties that there are several ways of violence, that violence can impact a workplace. The 4 types is type 1, external, so the criminal type of violence, external to the organization. Type 2 could be your client or customer violence or aggression. Type 3 is your employee-related type of violence, which could be called harassment or bullying. And then type 4 is your domestic violence or relationship violence. Some workers are more at risk for violence in the workplace based on the nature of their workplace, the type of work they do, conditions of that workplace, or maybe circumstances specific to the workplace. Certain sectors pose greater risks for violent workplace victimization. For example, employees that frequently come in contact with the public or clients are more likely to report being a victim of a violent incident. The following list are risk factors associated with workplace violence. The list is based on risk factors outlined by the National Institute for Occupational Safety and Health. And this list includes working in the community, working perhaps with volatile clients, handling cash, direct contact with clients, working in high-risk areas, high-crime areas, securing or protecting valuables, transporting people, or perhaps working alone or in small numbers. Several of these activities or conditions may apply to your workplace. In addition, there may be other risks in your workplace. Examples that include working late or very early hours, perhaps serving alcohol, and in some places the risk of violence may be higher at busier times of the year. Occupational groups that are more at risk include our healthcare employees, our correctional officers, social services employees, teachers, municipal housing inspectors, public works employees, and retail employees. Due to the types of work and or conditions of work of these organizations can put these workers at higher risk from workplace violence, generally from strangers, clients, customers, or patients. Research shows that workplace violence is 3 times more likely to occur among healthcare workers than any other occupation, including police officers and prison guards. In 2015, research has shown that as high as 31.8% of lost time injuries due to workplace violence has occurred in the healthcare sector. In Canada, out of 34 occupational categories, more workdays were lost among nurses than any other category. In Canada, employers do have the legal duty to protect employees from workplace violence. Provinces that are regulated to have workplace violence prevention include Alberta, British Columbia, Saskatchewan, Manitoba, Ontario, Nova Scotia, Newfoundland and Labrador, and Prince Edward Island. Federally regulated workplaces have specific workplace violence prevention regulations. This falls under the Canada Labour Code Part 2. Quebec has legislation regarding psychological harassment, includes forms of workplace violence. The following in Canada can be considered either a best practice and or a regulated requirement. Employers should prepare a written workplace violence and harassment policy. The policy perhaps is a best practice or a regulated requirement to be posted within the workplace, and the policy should be reviewed at least annually. When developing and maintaining a program to support the workplace violence and harassment policy, our policies program should include definitions of workplace violence and harassment. The program would include a risk assessment, that list of risk factors that we had identified. What risk factors are within your workplace? How are you identifying those risk factors and then applying the correct controls to control those risk factors? Emergency response if controls are not effective and the situation escalates. A written process of how do we report violence or harassment, and then steps of investigation, corrective measures, communication back to the employees that are involved, and then training on our workplace violence prevention program. Some other requirements that may be regulated or a best practice is informing and instructing the worker in the respect of the workplace violence program, but also communicating to persons with a history of violent behavior. So a client, a customer, a stranger, perhaps, that has been at the workplace in the past. And how do we communicate that this person has been here, has had escalated behaviors, and what types of controls or prevention programs are we putting in place to decrease workers' exposure to that history of violence? Reasonable precaution. The second bullet talks about domestic violence. In Ontario and perhaps other organizations as a best practice, they include a reasonable precaution made by the employer to protect the worker from domestic violence in the workplace. Domestic violence may be a form of physical violence in the workplace, and if it is in the workplace, it is the responsibility of the employer to ensure that they're keeping everyone safe. And the last part is, how do we ensure that we exercise and understand our right to refuse work if workplace violence is likely to endanger the worker? Within the healthcare sector, literature defines type 2, the client-customer violence, as being either violent or aggressive responsive behaviors. The difference between the two: violence is the willful intent to cause harm. No contributing physiological or psychological condition rendering a person incompetent. So the intent is there, that's violence. But in healthcare, if our patients or consumers or residents have responsive behaviors, we consider that as no intent to cause harm. There's underlying physiological, psychological conditions that are causing those responsive behaviors, often results from the inability to communicate a need and responding to a situation or a stimulus. So the literature defines aggressive responsive behaviors as a protective means by which persons with dementia or other conditions may communicate an unmet need or reaction to their environment. Now that we understand that the percent in violence in Canada is high and very prevalent in the healthcare sector, how can we proactively lower the risk of client violence or aggression from happening? One recommendation is the development of a sustainable responsive behavior prevention program. There are 5 steps in developing a responsive behavior program. These 5 steps that are outlined in your slide are the 5 steps that Public Services Health and Safety Association promotes for the development of any type of prevention program. 1, you need to have a secure management commitment. You do, step 2, need to assess what are your program needs. Step 3 is now developing a program and understanding the master plan of how we're going to decrease the hazards. Then the implementation of the program, and at the end, how are we continually evaluating the program and making improvements? So our first step of secure management commitment. Management commitment is to ask the right questions, have active participation, communicate the right message, organize priority. How are we actually making our employees understand that this is a priority in our organization? Empower the right people, so assigning responsibility and accountability. And then allocate the right resources, which would include time, and money. Step 2, assess your program needs. The following slide outlines some suggestions of how to assess your program needs. Internal documents may include the injury demographics. Injury demographics are reactive, but definitely a process that we should evaluate where we are compared to perhaps other sectors. Workplace violence risk assessment. In some jurisdictions, that is a legislative requirement for every work site to complete a workplace violence risk assessment. Individual client risk assessment. So how are we actually identifying the potential or real situation that we are going to have violence, especially with the first contact with a client or a person? And then employee perceptions. How do they feel? Do they feel empowered of understanding and controlling the situation? Internal demographics, injury demographics, PSHSA does have a free template if you're looking for something to compare with what you have, or access something to compare organizational monthly analysis of incidences. You could use this specifically for workplace violence, the different types of violence that you may be exposed to at your work site. The second bullet is the workplace violence risk assessment, and this specific tool comes from our Barb project, Violence, Aggression, Responsive Behavior, and it's developed specifically for the healthcare sector. I am going to show a slide of the details of this workplace violence risk assessment. It is free to download from our website. Workplace violence risk assessment, any sector. Now, it doesn't matter if you're in transportation, farming, retail, healthcare, education, municipalities. This is an e-tool that you could use to determine what are your risk factors on your work site. It also provides you with suggestions of controls if in fact that risk factor is prevalent for your organization or your work site. Employee perceptions. PSHSA does have a client aggression employee survey. You can contact eConsulting or myself, and we can provide you with a sample of this employee survey. The individual client risk assessment tool. I'm going to spend a few minutes now discussing this tool in quite a bit of detail. The individual client risk assessment tool is an internal document that provides a snapshot of a client's immediate risk of violence. It was designed to help care providers identify risk factors and levels associated with workplace violence. By conducting regular client risk assessments, providers can apply control interventions that promote both employee and client safety, as well as ensure client-centered care. The individual client risk assessment should be applied at first contact with a client and on an ongoing basis, depending on your client population, individual client circumstances, and your employer's operational policies. To explain the tool and how it works, the first step that it identifies is the history of violence. Some jurisdictions does need to identify and communicate persons with a history of violence. So that's the first piece of information to meet legislative requirements. If it's not a legislative requirement for your area, then this would definitely be a best practice. So we're looking at past occurrences of exercising physical force, perhaps attempting to exercise physical force, or maybe there was statement or behaviors that could reasonably be interpreted as threatening to exercise physical force. The tool then wants to capture observed behaviors. Observed behaviors that we are identifying would be confused. Its descriptors as disoriented, unaware of time, place, or person, perhaps irritable, easily annoyed or angered, unable to tolerate the presence of others or unwilling to follow instructions. Boisterous, overly loud or noisy, slamming doors, shouting. Verbal threats, raising a voice in an intimidating or threatening way, shouts angrily, insulting others or swearing, makes aggressive sounds. Another behavior to identify is physical threats. Perhaps raises arms, legs in an aggressive or agitated way, makes a fist, takes an aggressive stance, moves or lunges forcefully toward others. Attacking objects, throwing objects, banging, kicking, smashing furniture. Perhaps they're showing agitation or impulsive, so they're unable to remain composed, quick to overreact to real or imagined disappointments, troubled, nervous, hasty, or emotional. Other behaviors is paranoid and suspicious, substance intoxication or withdrawal, socially inappropriate or disruptive behavior, and perhaps demonstrating body language. Body language meaning torso shield, so their arms are acting as a barrier or have an object acting as a barrier. Puffed up chest, so territorial dominance. Deep breathing or panting. Maybe eyes, the pupil dilation or constriction, rapid blinking or gazing. These are all types of observed behaviors that we want to identify that have a strong correlation to violence. From there, once we have identified the behaviors or perhaps the history of violence, we get a risk rating. For every check or every observed behavior, it gets a check, which increases the risk rating. So the risk rating is determined by the number of violence risk indicators that were identified. The risk specifics suggest interventions have been provided. They can then check off the interventions that would be implemented for this client. So on the screen, we have, for example, if I was to go through all these behaviors and check them all off as being yes, being present, the risk rating actually comes out very high. And the way the tool works is now it will pull up or it will identify possible controls that you can put in place to help decrease the risk rating. So you would have clicked or checked off what is applicable for your organization. The next part of the tool is looking at contributing factors. There are certain factors that can lead to or perhaps escalate violent, aggressive, or responsive behaviors. These factors tend to fall into 4 categories: physical, psychological, environmental triggers, and activity triggers. Documenting the known triggers and behaviors by asking your patient, client, or perhaps the substitute decision maker will help identify and manage more effectively and safely. Use the information collected and intervention resources listed to develop an individualized violence prevention care plan for that patient or client. And then that will allow an increase in protection for the worker. Once you've identified the contributing factors, we have a list or a section for prevention measures, so we can check off the ones that are applicable for this person, making a person-centered care plan. And again, identifying what are those de-escalation techniques. So if prevention did not work and we now do have an increase in behavior, what can we do? What types of techniques would be appropriate for this person to de-escalate them? A very person-centered care plan. So perhaps you're not in healthcare. This tool was designed specifically for the healthcare sector, but perhaps you're not in healthcare. It still can be used in any sector. You may need to tweak it, but the most prevalent areas that you could use: history of violence. You are communicating that this person has been at the workplace before, has a history of violence, explaining what it is that they've done and what type of controls will you put in place to prevent it from happening again. Observed behaviors. Behavior is behavior. Confused, irritable, boisterous, verbal threats. You don't have to be in healthcare to associate that with violence. The police department, the EMS, the fire department, the librarian, the healthcare, the education person, the tax collector. These are all areas that would have a high increase exposure to perhaps clients with, or consumers or customers with violence. So how can we empower our frontline staff with behaviors to identify that may be correlated in this area as violence, and empower them with controls if we do see them? So an opportunity is there to utilize the tool in any sector. So the question always comes up, especially in healthcare, well, how often am I required to complete an individual client risk assessment? Well, we do absolutely recommend that you do it at first contact with the client as appropriate based on your sector or organization. And then according to your policy and procedure. So it may be prescribed that you're doing it monthly. It may be prescribed that you're doing it annually. It depends on the sector. In healthcare, one of the areas that we look at that is a high risk for violent behavior is acute care, long-term care, and the group home setting. So we do suggest that in acute care and long-term care, we do it at the initial contact with a client, every new client. And then perhaps it's going to be based on the department or the area that the person is there admitted to. So if it's a high-risk area, perhaps mental health in a hospital, for example, a high-risk area for violent behaviors, the risk assessment, the individual client risk assessment, may actually be done at the beginning of every shift. So they have early identification and appropriate controls put in place. So it's more proactive rather than reactive. Step 3 in developing a program. Developing a policy. In this individual client risk assessment toolkit, we do provide a sample policy. The sample policy covers the purpose. What is the individual client risk assessment tool? A statement providing policy wording, a sample. Definitions that may or may not pertain to your organization, but does provide a glossary of key terms that you want to ensure that if you're using, people understand what you mean. Roles and responsibilities. Who is actually responsible for the health and safety of your organization? It is the internal responsibility system. It is the responsibility of everyone within the organization. So how does that look for this prevention program? Who implements it? Who supports it? Who evaluates it? Procedures. How's this program implemented? How do the procedures tie into the rest of your health and safety management system? And then communication and training, employee orientation, and annual training. Then how are you continually going to evolve? So evaluation and continuous improvement plan. Developing a program, I like to call it my master plan of how this type of program is going to function. We ask ourselves who, what, where, why, when, and how. And it's the master plan for sustainability. Best practices that we incorporated into the sample policy are categorized intervention controls, which are into 4 different areas. The literature supports these 4 areas as effective areas for addressing responsive behaviors: physical environment of the work practices, staffing, and training. Within these 4 areas, we look at the hierarchy of control measures. So how can we eliminate the hazard? Maybe engineer solutions, reorganize and provide training, or provide personal protective equipment. Step 4, the implementation of your prevention. Oh, excuse me, my screen has gone blank here for a second. Just give me, there it is. Sorry about that. Implement the program. So critical steps. It is not enough just to have a written policy. It is not enough just to provide hands-on training. You should have critical steps that you're implementing the program for sustainability. One is to ensure the development of responsive behaviors, prevention policy, and procedures. Ensure that you have a communication and marketing plan. How are you communicating the who, what, where, when, why, and how, and the priority for this implementation of this program? And then develop and present staff training and launch the program. Informed and educated is the future for empowerment for our frontline staff. Some tools that we developed with the individual client risk assessment toolkit to help with the implementation of the program. Here is a way for communication and training. The individual client risk assessment poster. So a reminder, what are the risk factors that we're looking at? How do we assess the risk? So the individual tool, the checkbox is there listing. And then the number of checks that we've identified will give us a risk rating. And then what are suggestions to take action and involving the client? So an opportunity of reminding our frontline staff of what is an individual client risk assessment. We also developed these pocket cards so they could perhaps fit as like a cue card in someone's uniform, or perhaps on the back of a name tag, the necklace type of name tags that we have. Again, communicating and educating what are those risk factors that we want to identify, or the responsive behaviors that are associated with violence. Common question: how often should employees be communicated and trained on workplace violence prevention? An employer shall provide a worker with information and instruction that is appropriate for the worker on the contents of the policy and program with respect to workplace violence and any other prescribed information or instruction. Some jurisdictions prescribe that the policy is to be reviewed annually and posted. Workplace violence is to be included in the orientation program and annual review training as outlined in your prevention program. The last step in developing a responsive behavior program is evaluate the program. We need to know, is our program current and meeting our legislative requirements? Have we incorporated what's reasonable, our best practices? Are we evaluating our controls? We want to ensure that what we assess as being risk factors and assigned as being controls are actually effective. Our communication and training effective. And if we've done a great big training blitz and we go out 3 months later and employees are not aware of our prevention program and our controls or how to report to prevent, then that is an ineffective communication and training program. Is there a decrease in injury? Yes, lagging indicators are important to look at as well, but not just lagging indicators. Ensuring that we look at leading indicators, how we're proactively measuring this program. Is there an increase in hazard reporting? That's a good thing. We are detecting our hazards before an injury happens. We want that to happen. Are we actually following our policies and procedures? So are we compliant to the rules that we've assigned within our organization for prevention? Those are the 5 steps in the development of our responsive behavior prevention program. The next few slides are going to talk about client aggression responsive behaviors, or the Barb tool that I have mentioned a couple of times now. The Ontario Ministry of Labour recognizes the growing concern of workplace violence in our healthcare sector. The Ministry of Labour actually awarded Public Services Health and Safety Association with funds to develop an evidence-based workplace violence toolkit. The goal of the project was to deliver a model, an evidence-based toolkit that provides workplaces with sustainable outcomes and thereby reducing incidences and the impact of violence, aggression, and responsive behaviors. How Public Services Health and Safety Association started this project 2 years ago is we actually got representation for our various stakeholders, representing various unions, management level, and frontline staff level, looking at acute care, long-term care, community care. Police services were involved, and EMS. And we developed a steering committee which actually worked in consultation with our consultants of Public Services Health and Safety Association, and we decided on 5 priority areas. The toolkit of the 5 priority areas that we wanted more information and resources for were 1, workplace violence risk assessment tool. It is a legislative requirement in Ontario to complete a risk assessment for every work site. Then we wanted the individual client risk assessment, so proactively identifying the potential for violence. Flagging handbook, how can we communicate persons with a history of violence? Security assessment tools, how are we ensuring that our security systems and personnel meet the qualifications and requirements based on the level of risk associated in our organization for violence? And then our personal safety response systems. How can we effectively call for help and various levels of risk for violence? So the first tool, again, we put a focus group for each of these tools that reported back to the steering committee. And the first tool was the workplace violence risk assessment. I did provide you a link in the beginning slides around internal documents to capture the level of risk for violence within an organization. I also have another link in the next slide or two of how to access all these free tools. But the workplace violence risk assessment toolkit, actually what it's looking at is assessing the physical environment of the work site. It's assessing the department or unit specific risk factors, and then how are we at risk when we're providing direct care. So the different types of care procedures that we have in the various departments may increase our risk for violence. What organizations or types of healthcare organizations could use this workplace violence risk assessment is primarily for the acute and long-term care organizations. Who should be completing the risk assessment? Multidisciplinary team. Very proactive and participatory is what we're looking at, including frontline staff of various disciplines within your organization. And then how often do we do this? We recommend at least once a year, more frequently when there's changes. We did already talk about the individual client risk assessment. This was the focus group that I had led for Public Services Health and Safety Association. And the toolkit, what it includes is the violence assessment tool, so identifying persons with a history of violence, looking at observable behaviors, looking at contributing factors, preventative measures, and de-escalation techniques. We did provide a sample policy of the who, what, where, when, why, and how, so the master plan for maintaining this program. We also included an appendice of sample interventions that identifies those 4 main areas that the research supports as effective means for controlling individual client violence. Where should we actually put, oh, sorry, I forgot the last two bullets there, that pocket card and poster. So for implementation, some tools are also provided in this toolkit for communication and training. Who should be using this type of tool? Our suggestion is acute care, long-term care. It's applicable also for emergency services and community care. When healthcare provider healthcare provider or manager, supervisor, and then when first contact, and then according to your organization's policies and procedures of how often you actually do it after first contact. Flagging. Some jurisdictions are legislated to communicate persons with a history of violence. In healthcare, this is very complicated because we also have privacy issues that we don't want to disclose any types of private information of the patients or clients that we're servicing. So we did provide privacy fast fact. Our focus group here, HAPI group, were employee advocates, and HAPI group were patient advocates. So what we did is we developed questions, we submitted it to lawyers, and they developed a privacy fast fact to identify what legislation actually supersedes the other in Ontario to allow us to disclose persons with a history of violence. At the end of the day, the Occupational Health and Safety Act of Ontario actually says that it does supersede all other acts, as long as we're not disclosing too much information. So we can disclose that there was a history and what corrective measures are in place. We do not need to disclose any further information that would be in violation of Privacy Act and other types of acts for privacy for our patients. We have a handbook to provide suggestions of what makes sense of flagging procedures in different sectors, sample policy to support the who, what, where, when, why, and how of this program, and a sample patient brochure so they understand why are we actually flagging them. It's a conflict of interest in some organizations, and so communication is really, really important to understand. It is for the safety and best practices for the patient and for the employees within the organization. Where should we implement this? This tool primarily was developed for the acute care sector, but definitely can be tweaked for the long-term care or community care sectors. Who should look at this information, assist with this information, is all staff. And when we want to flag when we have moderate to high risk for violence. Security. Security in Canada, we do not have a golden standard, a CSA standard or a best practice or guidelines to help us identify what types of security systems or qualifications security guards should have in various sectors within the healthcare setting. So we did refer to the literature and the best practices and standards that are out there in the United States, and we developed 8 tools to help identify gaps within our own prevention programs, policy, qualifications, training, communication. So free to download some very good and detailed processes for identification for security. Where should we have the security, or where should the tools be most applicable for this toolkit? The acute care, long-term care, and the community care sectors. Who should be actually using this toolkit? Security personnel, those responsible for security. And then how often should we reassess? We say at least once a year, more frequently when circumstances change. And the last of the 5 priority toolkits that we developed is the personal safety response system. And it's not quite finished yet, so it will be posted on our website very soon, hopefully by the end of June is what we're striving for. What this tool provides you is it supports the workplace preparedness and response activities and helps employers integrate PSRS into a workplace violence prevention program. Most effective for acute care, long-term care, and community care. Having a multidisciplinary team involved in the identification of what's best within the organization, and then reevaluating what you're using, how it's working. Best practice would be on on an annual basis or more frequently if circumstances change. So how can we access all these Barb tools? At pshsa.ca, you will access them at the Workplace Violence landing page, and you will see, if you scroll down on that home page, PSHSA Violence, Aggression, and Responsive Behavior, the Barb project, and learn more, and it will list all the tools, the details, the history behind it, the information on how to use them. This slide is just promoting an international conference that's actually coming up in Canada. It's in Toronto, and it's looking at violence in the healthcare sector. So an opportunity to save the date and perhaps attending the session if that's applicable for your organization. So I'm more than welcome to help out with questions. I receive questions and answer them as best as I can.
Great, thanks Shelley. Lots of great resources in your presentation today, and I just want to reassure everyone that you will get the full slide deck as well. So I know there was a lot of links that Shelley had there, and you'll be able to access those tomorrow in the slide deck. So let's jump right into questions. Shelley, first of all, when you were talking about broad level statistics about workplace violence, would you say that women are primary victims, and are there any stats out there about you know, how the genders are affected with this?
And depending on the sector that you're in, some sectors are primarily women. So the statistics for women being exposed to violence is much higher in certain sectors. So I would say yes, women are primarily subject to violence more than men, and statistics would support that. But again, it would be very prevalent to what sector you're servicing to be prevalent.
Okay, and now we did talk a fair bit about healthcare in this session, and we did have the question of what is it about healthcare that poses such an increased risk?
It's the clients that we're servicing and the situations that we're dealing with. You know, clients don't come to, patients do not patients do not seek healthcare services because they're feeling 100%. So we deal with mental health issues, we deal with high-risk clientele when they're ill. Emotions perhaps are driving the responsive behaviors. If perhaps you're a family member of a sick person, it's just the fact that we deal with volatile clients. We deal with high-risk situations. Those risk factors that I had identified is very prevalent in the healthcare sector. So if I was to go back to those risk factors that I were identified, we would identify almost all of them as being prevalent in the healthcare sector. So this slide will show you working in the community. So healthcare does provide community-based services. We deal with unstable and volatile people. We have mobile workplaces, direct contact. Some of our areas in high crime areas, we are securing and protecting valuables, transporting people or have goods, and we do a lot of times work alone or in small numbers. So just the risk factors that are associated with violence is very prevalent in the healthcare sector, which puts us at a higher risk.
Okay, and I assume it's probably similar situation also for social service or counseling organizations. We have had some questions about whether there are some resources available for people working in those fields, or would you suggest taking a look at what you've suggested here and tweaking it?
At this point in time, our organization developed those Barb tools very specific to the healthcare sector. And what we are doing at the very, very beginning stages, like the first month of working on it, we are actually looking to adapt, modify those Barb tools to help our education sector and our municipal sector. So we are in the process of tweaking, modifying those tools to make them more generic to service the non-healthcare healthcare people.
Okay, and we had some additional questions related to domestic violence in the workplace. So perhaps, Shelley, you could maybe just offer a few best practices or maybe just discuss that a little bit more.
So some best practices, obviously in Ontario, I believe it's the only province in Canada that is a legislative requirement that the employer demonstrate reasonable precaution for the protection of the worker against domestic violence. What reasonable precaution means is actually what type of program have you developed for prevention. So you could almost apply those 5 steps. I'm just pulling that slide up. The 5 steps say to address or to develop a domestic violence prevention program. How are we securing management commitment, assessing the program needs, developing the program, implementing and evaluating it? What we're doing is actually determining signs and symptoms and how do we report and how do we provide resources and support to our employees that may be in a domestic violence situation. Some scenarios that I have experienced as a consultant, just developing a program that speaks to the how-tos, the who, what, where, when, why, and how, actually opens up the door for a person that really does need help and actually has disclosed some very violent situations where we've had to develop safety plans for the employee because the domestic violent person is actually seeking them out at the workplace. So best practices is actually putting a prevention program in place, implementing it with communication and training, and always evaluating how effective it is.
Great. And when going...
sorry, Marina, one extra thing I just thought of. We do have a domestic violence handbook that's free to download off of our website. So if you went to ps@gsa.ca and you just Googled in the search engine domestic violence, our domestic violence resources will be there.
Excellent. We've had quite a few questions about that, so I'm sure that will be really helpful for our participants today. Now, just on that same topic, do you have any suggestions for how to navigate privacy while also, covering your duty to inform staff of risks?
Yeah, that's a complicated situation and a very hot topic, especially in the healthcare industry. You only have to disclose enough information to communicate that there was a violent situation. If I could very loosely put it in a comparison, for example, of infection prevention and control measures, we take universal precautions to prevent us from being exposed to biological agents. But if we have a known bloodborne pathogen, we don't disclose what that bloodborne pathogen is, but we do disclose that we have to take additional precautions. So what we do in Ontario is we will have a sign posted, for example, in a hospital setting, we'll have a sign posted outside the patient's room saying airborne transmission, additional precautions. We are not disclosing anything, so we're not in violation of any privacy situations. Same thing with the violence. We may have some sort of special wristband, for example, if you're being admitted into a hospital, perhaps instead of the generic wristband that tells you who you are and your number and all that sort of stuff, maybe this one is a red band. So now we're communicating that this person was here before and exercised physical force, attempt of physical force, or threat of physical force, and you as an employee need to take additional precautions. And you may have to maybe it's just a best practice type of additional precaution, or maybe in your organization you're looking at the actual communication engine that you're using to see what those additional precautions are. So we're not in violation of the Privacy Act if we disclose that the history was there in the past.
Okay, and the personal safety response system that you discussed,
Yes.
does that work if a person is off-site? So if perhaps a nurse is making a house call?
Yeah, so we will provide resources or suggestions of what that would look like if you were actually off-site. Yes.
Okay, and now sometimes some of our participants have offered situations where that they're dealing with the general public. They don't have a lot of history on the clients that they're dealing with. You know, and perhaps someone is exhibiting some slightly inappropriate behavior. Sort of, what should they do at that point? They're feeling a little bit uncomfortable, but perhaps it's not quite at a level of aggression.
Well, I always say that, you know, if any type of behavior, if it's inappropriate behavior, but not actually aggressively seeking out the employee or signs of violence to the employee, it's your internal process of how you're going to identify or report and take corrective measures. So personally, I can't prescribe what that looks like for this person's work site, but definitely communicating and educating our frontline employees of what they believe in their workplace is inappropriate or socially inappropriate behavior. And if we see it, how do we report it and how do we deal with it? So it would be your internal policy and procedure for socially inappropriate behavior.
And does that also qualify for phone calls? So if someone's receiving verbal abuse or, you know, inappropriate
Absolutely.
behavior? Yeah, okay.
Yeah, absolutely. Yeah. Yeah.
Excellent. Okay, great. Well, I think we're going to cap it there because I see we're running close on time here. So I wanted to thank you, Shelley, so much for joining us today. It's been a very informative presentation, and I know you've provided a lot of resources for our attendees to go and check out as well. So thank you.
Thank you very much for this opportunity. Thank you.
Wonderful. Well, just before we sign off, I do want to remind everyone that we're going to follow up with you by email tomorrow with the webinar recording. So we will have a link to a short survey there. If you can take a moment to fill that out, that's super helpful for us. You can have an opportunity to let us know if there's future topics or presenters you'd like to see us feature. So please do fill that out. And again, like I said, you will get the recording and the full slide deck, so you will have all of those resources available to you. Thank you again, everyone, for joining us today. I hope you all have a wonderful rest of your day. Thanks again.
Thank you.